network has expanded now, and it's part of Northwell. For you guys that don't know that, Northwell just acquired Nuvance, so we're now part of Northwell Healthcare. So it's going to be a big enterprise, but we do help quite a bit of patients in Connecticut, and I wear many hats. I do pulmonary medicine, I do critical care medicine, work a lot in the ICU, but one of my passions has always been sleep medicine. For a number of reasons, one of which is I feel it's a surgical type of specialty, believe it or not, because you can change somebody's life overnight by just a few things. And that may apply to some specific conditions, but believe it or not, it's a very rewarding field because of how much sleep impacts on all your health in general. And it's, for years, has been a field that has been ignored, but over the last 20 years, I feel that the medical community, the scientific community, has put more emphasis in the importance of sleep and how it impacts your health. So what I wanted to do today is kind of go over a few topics just to organize the presentation. One is I'm gonna try to see if I could give you some idea as to where are we now in answering the question of why we sleep. Believe it or not, we still don't know that. So there is no good answer to it. We have some ideas, and after years and years of research, we have learned some things about why we sleep and the function of sleep. But even though it seems like a very simple question that we should have known by now the answer to, we still don't know the answer to it. I'm going to go over some basics of sleep physiology, not because I want to bore you with slides, but mainly because I want to show you the main things that I look at in learning about your sleep physiology when I design a treatment for you. So when I see you in the office, I ask questions about your habits, your bedtime, your wake-up time, and all of that is very directly correlated to your body temperature and how I can modify, for example, the room temperature, how can we impact the light influence on your sleep and such. So learning about how we sleep or how the humans sleep is important because it gives you an edge to treatment. Then I'm going to go over some specifics about the more common sleep disorders, and I'll talk about perhaps the most common of all of the sleep disorders, which, believe it or not, in today's age is sleep deprivation and insufficient sleep. It's not, you wouldn't think it's insomnia or sleep apnea, but actually the more common of the sleep disorders is not sleeping enough. And a lot of that has to do with our own doing. I'm going to take a deeper dive in some of the effects of sleep problems in health, particularly cardiovascular health, which is my research interest. I did a lot of research at Mayo Clinic, and my interest was on sleep and cardiovascular health, specifically how sleep deprivation and sleep apnea can increase your risk of atrial fibrillation and acute myocardial infarction. We'll go into some studies that I've looked at. Every time Kevin invites me, I do a little bit of an update in my review of the literature about what's up new about cancer and sleep. There had been a bunch of new studies, and I'm going to mention that in the slides, so you'll have those references, looking at the association between fatigue, cancer treatment, depression, and sleep. We'll talk a little bit about cannabis because Kevin asked me to comment on it, and what do we know about that? Does it help? Does it not? So that's sort of the outline of what we're going to talk today, but I wanted to, again, make it very informal, jump in, ask questions. Kevin wants me to answer the questions at the end, but if there is a pressing issue you want me to slow down or stop, please, by all means, do. I love this picture because this is how perhaps everything started in sleep medicine. This is Nathaniel Kleitman, this guy here sitting, managing his equipment. One of his students, Bruce Richardson, was the guy who is laying in bed. This was in a Kentucky cave back in 1936. 1936, 1938, that's when he started doing research in an isolated, dark environment, free of any stimuli. And what his interest was, he's considered the father of sleep research, and he was studying at that point the circadian rhythm. And his interest was, if we isolate a human being from all the stimuli from life, particularly meals, light, exposure, sound, noise, etc., what would the sleep be like? And these are the times when we still didn't have a clue of what our circadian rhythm was and how it will influence our bodies. And so I like that because it kind of gives us a little bit of perspective as to how recent this field has been, 1930s, and we didn't know much about anything. And that was perhaps the first study about sleep and the first sleep study. For those of you who like to have references about this, this is what I'm reading right now. And it's a book that I just picked up. It's from Kent Miller. It's called Mapping the Darkness. And for anybody who wants to learn about the history of sleep medicine and who are the pioneers in the sleep field, it's a well-written book, beautiful, tells you the story of how things unraveled to take us to where we are now. It's a great book. It's a good read. I mentioned to you that I wanted to try to see if I could answer the question of why we sleep. I still don't know that I know why we sleep, but these are the main theories of what we think happens during sleep. One is body repair, brain restoration. We know that there is some energy restoration during the time of sleeping, memory and learning and unlearning, which is a way of the brain discarding stuff that is not needed. We know that there is a big association with immunocompetence and immunity. And this is something that we learned very quickly and rapidly during COVID, where patients that were sleep deprived or had sleep disorders tended to have a worse prognosis, kind of a very classic example of a devastating immunological disorder associated with an infectious disease. We know that sleep has some participation in thermoregulation and energy conservation. So it's another obscure area of research. And homeostatic synaptic, which is neuro regeneration. And in a way, the way you think about this is like, neurons connect between each other. And when there is a disruption, it seems like the repair process occurs during sleep, particularly when we think of connections of neurons as the way that we make thoughts. Any ideas, anything you learn, like when you're hearing something that I'm telling you now that you didn't know, you will learn, there will be a neuron as we speak that will be connecting to another one. So that's what happens. But perhaps the newest of the theories, and the one that still stands up to recently, and the reason why I say up to recently is because I was just reading Nature, which is a medical journal, research journal recently, and there's already a paper that may be debunking this theory. So as you can see in science, what I tell you now may not be true next week, and things are evolving very rapidly. Let me introduce you to this concept, and I'm not going to make it complicated. Trust me, this is something called the glymphatic system, which is a system that is surrounding the vessels of your brain and is around the arteries and the veins. And the idea is it's a system that is intended to drain chemicals from your body during sleep. Christensen wrote this in Neurobiology, which is a very prestigious neural journal, and basically reported this. And everybody started studying this system and trying to assess whether or not it had anything to do with sleep. And lo and behold, we learned very quickly that one of the main functions of this glymphatic system was to drain amyloid beta and tau. Now, amyloid beta and tau are two proteins that have a very bad reputation. These two proteins are the ones that are responsible for Alzheimer's dementia. And if accumulated in your brain, they lead to neurodegeneration and rupture of connections, and that is what leads to dementia. And this system clearance from sleep seems to be almost exclusively active during sleep. So there you go. It seems like the sleep was our garbage man there, and it was responsible for getting rid of these proteins. And if you don't have enough sleep, therefore you'll be having this accumulation of proteins in your brain, that are not good for you. So it's a very interesting theory. As I said, is the one that stands right now as the most important one. And every day there is a paper that shows how this system cleared X, Y, or Z protein from the brain, which is kind of a waste that needs to come out of your system. So it seems like we absolutely need sleep, and that's one of the main functions of it. But now that we know, or we think we know, why we sleep, let's say what controls sleep. This is something that I learned over time to explain to my patients very early on, because the earlier you realize what controls your sleep, the earlier you realize what you're doing wrong to fight it. And in a way, I'm saying fighting it because when we talk about sleep hygiene, you'll realize very quickly that a lot of the things you are doing with good intentions may be actually counterproductive, may be actually going against your biology. So one of the systems that controls sleep is very simple, like a rubber band, how long we've been awake. And if you think of a rubber band and a sleep, you know, the more you extend that rubber band, the more pressure to get to sleep. The longer you're awake, the quicker you're going to fall asleep. And there is a chemical called adenosine, which is built up in your brain as we stay awake. By the way to block adenosine is coffee. So if you drink coffee, you will block the receptors of adenosine, and you will make that pressure much more weaker. Therefore, you start thinking, maybe I should limit my amount of caffeine, right? So maybe instead of 4 or 5 cups of coffee, I can live with 1. And a lot of patients in the past tell me, well, but I only drink coffee in the morning. I don't do anything past midday. My doctor told me it's okay. Well, now we know that every single cup of coffee you drink, even in the morning, has effects at night. So I'm sorry, but if you are a coffee drinker, coffee lover, and you have insomnia, you should start thinking of getting rid of them, of that caffeine. And I say that as I drink my mate, by the way, which has caffeine in it. But and I'm sure some of you guys are sipping coffee. I saw Kevin, or I don't know, Kevin is drinking tea, I think, likes tea. Now, the other system that is involved is something that you have some control over, but it's a clock that kicks in regularly and is embedded in your brain and has control over the level of alertness according to day and night, and cycles every single day in a 24.2-hour cycle in alertness, less alertness, alertness, less alertness, and it's something that is into your brain. I'll show you what it is. You have some power of modifying how the circadian rhythm moves by adjusting your exposure to light. So that brain center can be affected by a number of things, the main one of which is light exposure. So manipulating that can help you sync in better with your circadian rhythm. And for those of you who work at night or do night shifts, have to adjust that, because otherwise you won't be able to sleep during the day. So let me introduce you to the suprachiasmatic nucleus, which is a very tiny, tiny little spot right in that area. These are the pictures on the brain. And it's the center that, just like a clock, kicks in and gives you the level of alertness you need during the day and suppresses its function by modifying chemistry in the brain to get you to sleep at night. So this is a couple of pictures that I put into to show you how this combined process S, which is the adenosine cycle, how long you've been awake, combined with the process C, the circadian rhythm, in combination is what determines when you're feeling sleepy as the evening comes in. So right now, our process S is starting to build up. You know, we are starting to build up adenosine, still early, but many of us that go to bed early, you know, start accumulating that chemical in their brain. And the process C, the circadian rhythm, is starting to give up and is starting to say, okay, maybe time to go to bed by 9, 10 p.m. So this, you know, combination of factors is what controls our sleep. And we do have an effect on it. Now, from the structural standpoint, you may have heard about REM sleep or REM sleep and non-REM sleep or NREM sleep. And different stages, 1, 2, 3, 4, 5, are numbers that just show how deep you get into. Slow wave sleep, which is stage 3 and 4, is where most of the restoration of our bodies occur, as opposed to what people think. You know, a lot of people ask me, how much REM do I get in, in the sleep study, because they're worried about they're not going to have enough REM. Well, REM sleep is a very active sleep. It's actually one in which we burn calories. Our bodies are really working hard. Our respiration is very irregular. Our heart rate is fast. We dream. We burn a lot of calories. Our brains are very, very active during REM sleep. Now, when we really rest is in slow wave sleep, believe it or not. And if you look at the perfect sleep, which is probably from a preteen, it has a lot of slow wave sleep. They probably, I would say 40, 50, 60, 70% of their nights is all slow wave sleep. They have very little REM sleep. But in general, we go through 4 cycles of REM every 90 minutes. So every 90 minutes, you get a little bit of REM sleep. All of us dream. Most of us don't remember the dreams. Our bodies are intentionally making us forget all of that time. And our bodies paralyzes our body during REM sleep. So our bodies are not moving around. Otherwise, you'll jump out of bed and start acting after a dream, which is on itself a disease or a sleep disorder. Kevin asked me to give you a little bit of a picture of how sleep is throughout the age. And in general, you can see that as we are a kid, when you're a kid, you have a lot of slow wave sleep. This is the brown portion. Slow wave sleep is the portion that gives us the most restoration in our body. This is REM sleep. This is wake after sleep onset. That's WASO. And that stage 2 and 1 is the very superficial sleep, which is pretty steady throughout the ages. If this is a 50-year-old person, this is a 25-year-old person, middle-aged man, will have a little bit of each. But as we age, we have less and less slow wave sleep. Our REM sleep also comes down. Our superficial sleep stays about the same. But look at what happens as we age. As we get older, we spend more of our nights being awake. And that's okay. And I want to debunk that theory that I need to sleep in one single block. That's what it used to be thought as the ideal scenario. But in reality, that almost never happens, particularly as we get older. You will have multiple awakenings through the night. Sometimes to go to the bathroom, sometimes because you have aches and pains, sometimes because your body will wake you up. And that is actually by design, something that in human beings we haven't lost yet since the caveman era, which allowed us to wake up every so often to make sure that, a tiger wouldn't eat us, right? So there was a reason for that 90-minute cycle. And we still keep that in our genes. So if you wake up during the night, don't worry, you're a normal human being. Okay, so I think that many of us would love to have that all night long moment where you say, I wake up at 8 o'clock in the morning, I never woke up through the night. The reality is you do wake up, just you don't remember it, but that's by design, so that's normal. Now, there may be reasons why you wake up more through the night, and that could be a pathology, could be a condition, could be a problem, could be your cancer treatment, could be pain, aches, could be a lot of things. But, just to understand how the normal physiology is, in a normal human being, that will be nighttime awakenings. Now, when it comes to sleep disorders, I love this picture because I think it tells us how the medicine community thinks of sleep. They are here, these 2 kids or these 2 people taking a selfie and not realizing that behind them, they have this huge shark looking at them, ready to eat them out. And I think, honestly, medicine, and I'm talking about now the general practitioners, don't realize that sleep disorders are out there and they are the basic and the solution for a lot of things. And I think until we realize that sleep is a big part of what we do in medicine, we won't make any progress. particularly when it comes down to reduction in cardiovascular risk factors. So just to give you a kind of an estimation, we know that 70 million people have a clinically significant sleep disorder now. And a lot of them, and Kevin mentioned some of that already, 1/3 of the adult population have insomnia at some point, and almost 10% of the adult population in the US have chronic insomnia. So 1/3 of the adult population have insomnia in their life. That's expected. We go through a lot of things, stress, conditions, epidemics, disease, loss of a loved one, but 10% suffer this chronically. What do I mean by that? More than 3 months, having insomnia, not being fixed. And, sleep apnea, which OSA stands for, obstructive sleep apnea, is thought to affect almost 38% of the adult population these days. There is a huge association between obstructive sleep apnea and hypertension. And I want to make sure that you know that, because you are your own advocate, and I want you to talk to your doctor about sleep when you go visit them in your physical exam, because if you have hypertension, you need to make sure that you don't have sleep apnea. So that's one thing that I want to emphasize today. Now, I was telling you earlier that in my practice, when I do sleep medicine, I look for a whole spectrum of conditions. But one of the things that is the most common ones is sleep deprivation. We just don't sleep enough. Now, what do I mean by sleep deprivation? 7 hours or less of sleep. Now, that seems crazy to you because you're going to say, well, I never get 7 hours. Well, I have news for you. You are sleep deprived. Now, sleep deprivation is perhaps one of the most interesting of the research arenas we have right now, and there are forms of acute sleep deprivation, chronic sleep deprivation, and all of it has been clearly associated with medical conditions, the main of which is hypertension. Just to give you like a little bit of a recent data from the CDC 2020, this is self-reported sleep hours, and question is, on average, how many hours do you sleep in a 24-hour period? So this is a question just on the phone. And 30%, 40%, let's say in the Northeast, where I'm at right now in Connecticut, 30% of the responders said that they slept less than 7 hours. Interesting enough, there's a lot of the southeast of the United States states are notorious for sleep deprivation. West Virginia takes the winner as 42%, almost half of West Virginian population said they sleep less than 7 hours. This is just what people says they sleep. Now, it may be inaccurate, but it's a good estimation of what America is doing. We're not sleeping enough. Has to do with social media, has to do with toxicity from light, city light, electronics, stress of life, nutrition, etc., etc. So when it comes to medical effects of sleep deprivation, this is not inconsequential. Sleep deprivation leads to cognitive impairment, neurological issues, psychiatric problems, hallucinations even, attention deficit disorder symptoms. I see a lot of children, a lot of adults being treated for attention deficit hyperactivity disorder when in reality they are not sleeping enough. It leads to immune problems. It leads to diabetes, which is something that wasn't known until recently. It leads to growth suppression. I have a lot of children in my practice. I see pediatric sleep also, and that are sleep deprived for reasons including behavioral issues, but also sleep apnea. Obesity has been linked to sleep apnea. We'll go into a little bit of a deeper dive about that. And heart disease. So if you think about it, just by not sleeping enough, you could be making an impact on your health. Or the other way of looking at this is by sleeping longer, you could lose weight, you could reduce your cardiovascular risk of diabetes and heart disease, and you could be preventing things like, or helping prevent things like dementia. So it's a very impactful thing just looking at how much we sleep. Now, it's very popular these days to talk about weight because of the drugs we have available. But one thing nobody talks about, everybody wants to sell you Mounjaro and Ozempic, but nobody talks about sleep. And there is a direct correlation about weight loss and sleep. So let me show you what we know about that. Before that, I'll show you a map that, interesting enough, looks very similar to the one that I showed you before about sleep deprivation. And it's not coincidental, in my opinion. It almost looks almost identical over the colors, the darker colors meaning the higher percentages of obesity. Now, this is 2021. It's not updated, but it's gotten worse. Trust me. 30% of the population of the US on an average is a BMI 30 or more, obese. And Southeast being, again, perhaps the winners. The Northeast, we have about 20, 25, 30%, somewhere in there. Connecticut is 30%. So there is a clear epidemic of obesity in the US. And in my opinion, there is an almost mimic correlation with sleep deprivation. Why do I say that? Well, let me walk you through this graph. And I apologize that it's a little bit busy, but I want you to go through it with me. So let's assume somebody who sleeps less than 7 hours. Let's say someone who sleeps on an average 4 hours per night. If you measure their body's leptin, you'll see that they have a very low level of leptin. Now, leptin is a hormone that tells you that you have eaten enough. So if you have a low leptin, you will eat more. In addition, if I measure your ghrelin, which is the other hormone, and these are the hormones that are manipulated with the GLP-1 inhibitors, like, for example, Ozempic or Mounjaro, these hormones that are secreted in the stomach are the ones that regulate our appetite and hunger. So this balance of these hormones, including cortisol too, I'm not going to complicate matters too much, will lead to an increased calorie intake. So sleep-deprived people will eat more calorie-rich food. Think of someone who works at night and works in the intensive care unit. I do that a lot because I spend a lot of my nights in the ICU. You crave for ice cream, you crave for a bagel, you crave for a donut, something that has a lot of sugar and calorie in. So you have to fight that during the nighttime to prevent obesity. If you are sleep deprived, you have more time to eat because you are up all night reaching for the refrigerator and go and eat more calories. Your body temperature changes in a way that basically reduces your energy expenditure. You're not burning as many calories. And because you are so tired the next day, you're more likely to spend your days watching TV or listening to music rather than exercising, all of which leading to obesity. So, in summary, there is a very good correlation between sleep deprivation and obesity. So, in my practice, we are merging our efforts from the Sleep Disorder Center to our weight loss program. And we have a very strong program so that all the patients that come to us for weight loss, before they get prescribed medications to lose weight, we go over very specifics about their sleep. Let me show you a study, and I'm going to make this very simple for you. I don't want you to worry about the graph in detail, but this is a very interesting study. They paid people, I think they paid them like $500 or $1,000 to sleep more. So they divided, this is a control group, and this is the study group. So the black is a study group. And all they said is, in the control group, they said, sleep whatever you want. They put them in a room, and they asked them to follow their regular diet. They offer them food as they wanted, and they measure their calorie intake, and they measure their length of sleep. Now, for the ones that receive the money to sleep longer, they ask him to sleep 1.5 hours longer per night. So they actually did. They sleep longer, maybe on an average about this group, 2.5 hours, but in general, 1.5 hours for sleep. Looking at their diet and calorie intake, the group that slept 1.5 hours per night, nothing different. They didn't give them any advice as to what to eat or not to eat. They consume 300 calories or 270 calories daily less just by sleeping longer. So there is no question that adequate sleep leads to less calorie intake and better nutrition choices. So are there any questions up to this moment? If not, I'm going to move on to some specific sleep disorders that I want to go over with you guys. If there isn't any specific question, then I'll move on. We'll talk about sleep apnea, which is this condition where you snore and you stop breathing because of collapse of the airway right behind the tongue and the palate. In this MRI picture in somebody who is overweight, you can see the area where the obstruction occurs. Your symptoms are you snore loudly, you choke and gasp at night. The partner will tell you that sometimes you stop breathing and you have this episode where you snort yourself awake. You are tired during the day because you don't have a restorative quality sleep. And during the day, you're extremely fatigued, sleepy, tired. And many of us that have sleep apnea will end up with hypertension. How do we diagnose obstructive sleep apnea? We ask questions in the clinic. We do home testing, which is very popular these days, which is a little device that I'll show you some pictures of how they look. And we obviously do more in-depth in-lab polysomnography, which is the gold standard study to look at sleep disorders. Who is at risk of who can have sleep apnea? If you're looking at predictors, one of the things to look at is the neck circumference. I ask patients what size neck they have in their shirts, and anything over 17 inches in a man and 16 inches in a woman will predict highly obstructive sleep apnea. The presence of hypertension will predict obstructive sleep apnea. The snoring every night will predict obstructive sleep apnea. If the partner will tell me, and I ask, what is your wife or partner telling you about snoring? If you stop breathing at night, do you choke at night? Do you have snorts episodes during the night? If you have those, you are 80% chance of having obstructive sleep apnea. What are the risk factors? Being a man is a risk factor almost 2 to 3 to 1 compared to a female up until when you get postmenopausal. When you get to be in the postmenopausal age, that changes a little bit, and the odds equalize or even reverse compared to men. So men tend to have more sleep apnea in general throughout their entire life. When women get a little bit older and they get postmenopausal, then they catch up with us and they beat us in the severity and the prevalence of this. Men tend to have more severe apneas than women, but women tend to be less or more misdiagnosed because their symptoms are a little bit atypical. And how do women with sleep apnea present? Usually with insomnia, nightmares, or depression, which is not common in men. In men, sleep apnea presents typically with loud snoring and daytime sleepiness. Weight has an enormous influence in sleep apnea, to the point that there has been correlations of how much each body mass index point will impact their index of severity of sleep apnea. But in general, we think that almost 70% of people that are obese will have sleep apnea. And by obese, I mean a body mass index more than 30. Why? Because the obstruction that occurs behind the palate has to do with the deposits of fat around the airway, which makes the airway smaller and more likely to collapse. We look at waist-hip ratio, and I look at neck circumferences in male. We measure those things in every visit to have a kind of a graph and see how that impacts the severity of the sleep apnea. As we age, we tend to have more, there is a higher prevalence of sleep apnea. But interesting enough, the elderly population, it's a little bit more confusing because there is less of an association with cardiovascular risks. And we don't know exactly what to consider normal and abnormal in let's say, in an 85-year-old or a 90-year-old person. We do know that it's helpful to treat obstructive sleep apnea, even in the elderly, because there is always a cognitive benefit to treatment. So I treat aggressively all my patients, regardless of their age, as long as they're willing to receive the treatment. So in terms of diagnostics, these are two pictures of how home studies look like. This is one of the companies that we use for testing. Philips Respironics has this little device that you wear at night. It has a belt and a chest strap that goes around your neck. There's some sensors that measure your breathing. And these are other devices that are out there in the market, which are more modern and simplified. And just as recent as February of this year, the FDA cleared the Samsung Watch as the first wearable over-the-counter device to detect obstructive sleep apnea. So if you are so inclined to get into these gadgets, I have my Ring with me. I like it. This is, I don't have any company affiliation or anything, just so you know, but I like it. Aura is good company for measuring sleep, and I have an iWatch, and I can monitor my own sleep quality with those two devices. But this is coming. I think more and more patients are actually coming into our visits with data coming from their own wearable devices. This is the Respironics Night One device. It's a home test that we use very routinely in our lab. Home testing has gotten as simple as this. For example, this is the Night Owl device. It's a simple thing to wear in your finger. The WatchPad device is a very popular device. We use this during COVID because it's a single-use, throwaway device. You wear it in your wrist as a finger probe, and this is it. This is your sleep study. This is all you wear all night, and it transmits into your cell phone, and it tells me everything I need to know about sleep, at least sleep apnea. I was referring to my area of research, which is cardiovascular risks and sleep apnea. And in a simple form, I'm just going to show you some of the risks of untreated obstructive sleep apnea. Increases your risk of stroke by a twofold, risk of sudden cardiac death by twofold, cardiovascular disease fivefold, and atrial fibrillation, which is an arrhythmia in which your heart beats beat irregularly and you need anticoagulation because you have a high risk of stroke, by 30%. It's a very impressive association. We know that 122 million events occur per year in the US, and almost half of them are patients that suffer from obstructive sleep apnea. So when I look at patients that land in our ICU with any of these conditions, many of the patients that suffer from strokes will have sleep apnea undiagnosed. A lot of the patients have resistant hypertension, meaning hypertension that doesn't go well with medicines, will have sleep apnea. Arrhythmias, particularly atrial fibrillation, is a very common association. So this is a very important condition that needs to be diagnosed and treated early to prevent any of these problems. So more data, more of the same. We know that about 30 million people in the US have obstructive sleep apnea, and half of them don't know it. If you have hypertension and it doesn't go well with medicines, 85% of them will have sleep apnea. So 85% of the patients, that have persistent hypertension have obstructive sleep apnea, and about 30 or 40% of patients with regular hypertension, not the resistant type, will have OSA. So it's a very common association. So we heard about that atrial fibrillation risk, and so the risk of stroke goes up, like with atrial fibrillation. And this other complicated graph, I'm just going to summarize it for you. Between the obstruction on the airway, the obesity, and the breathing instability leading to sleep apnea, associated with a bunch of things that occur in your body between the low oxygen, the endothelial vascular dysfunction, inflammation, and metabolic dysregulation, meaning hormones that are off in your body, all of which will lead to heart disease. This is how, in 2017, Dr. Sawahari, who is a big researcher in sleep medicine and cardiologist, has summarized in a beautiful picture how breathing disorders during sleep can end up in cardiovascular disease. So how do we treat this? Mainly, we recognize the importance of weight loss. Alcohol and drugs can affect this. Position, believe it or not, how you sleep, on your back, off your back. We work closely with dentists, and we recommend for some patients that have mild sleep apnea, built-in oral appliances, which are devices that are worn during the nighttime and prevent the jaw from blocking the breathing. And we use a bunch of devices like CPAP, BiPAPs, which are masks that I'll show you some pictures of. Recently, we've done a lot of work, and I have started in Danbury a program with hypoglossal nerve stimulation. The brand name is Inspired. It's a company that created a device that is almost like a pacemaker, and the way that I explain that to patients, it's almost like a pacemaker for your tongue that stimulates the airway when it closes so that it prevents that obstruction that occurs when you are sleeping. And obviously, bariatric surgery and palate surgery still remains a backup option, although not a preferred option. So when it comes to CPAP, this is the CPAP that I have. I have sleep apnea, and this is the mask that I wear. It's a device that basically you wear on your nose or your nose and your mouth and pushes air in the back of your throat. I'll show you a cartoon that explains it, but basically the premises behind CPAP is by creating sort of a stent of air in the back of your throat, you have that airway open throughout the night without interruptions. So let me show you this cartoon. So that's a very simple explanation in a cartoon of how CPAP works. You have to have a device, a mask. There are many, there are 185 now in the market, different models of masks. This is like, I tell patients, like shoes, right? Each one has a different model of preference. The idea is you want to have a good seal so that air goes in the back of your throat and keeps this airway open without interruptions. So that's how CPAP works. A dental appliance, on the other hand, or an oral appliance, is a device that clicks into the upper teeth and lower teeth, and with an adjustment device that different molds, different types have different forms of this, are made so that the jaw gets protruded a little bit in comparison to the upper teeth so that this airway keeps open. So basically, a mechanical hold of your jaw in a way is what makes this airway, these devices work nicely too. That prevents the need of the mask. The downside of these devices is they're expensive. You have to have a sort of an evaluation by a dental expert and a dentist. And I usually work with a few in the community. Each areas have different ones. The American Academy of Dental Sleep Medicine has in their website the providers in your community that actually are board certified in sleep dental medicine. Talking about surgical options, when you go to see your ENT doctors, they may recommend removing polyps, doing a septal surgery, palate surgery, and obviously bariatric surgery. As I said, surgical options are kind of not my first line approach these days, but it's still available. Now, talking about the Inspire device that you may have seen on TV, I wanted to include this because this is something very popular these days. This is the control that patients get to activate this device. And let me explain to you how this is. It's a device that gets implanted in a one-day surgery. It's a very simple surgery. It's almost like a pacemaker. It gets put under your skin, has a sensing cable that senses your breathing, and has a small cable that gets implanted under your skin into the glossopharyngeal nerve. The glossopharyngeal nerve is a nerve that is responsible for the supply of nerve to the hypoglossal muscle, and the hypoglossal muscle is the one that moves your tongue. So in a way, think of this as a stimulation of the tongue when you're asleep with a microstimuli that keeps the airway open without you waking up through the night. It's intended for people that are adults that have a BMI or body mass index less than 32. So patients that are morbidly obese or obese beyond this number cannot get this device. For people that have moderate to severe obstructive sleep apnea, cannot tolerate CPAP or other treatments. So it's not for everybody. It's just for people that cannot tolerate any other form of treatment. And it requires a very extensive medical and sleep evaluation that we do in our sleep center. The studies have been shown since 2014, which was the beginning of this, up until now, that even at 5 years, the indexes of severity have persistently been low and the scale of sleepiness have improved. In other words, what I tell my patients is there's a good chance that this device will bring your severity of the sleep apnea at least by half, if not more. It's not perfect, it's not better than CPAP, but it's a very good alternative for people that cannot tolerate CPAP. Just in a simple couple of cartoons and pictures, I'll show you. This is a small picture of the palate behind. This is an endoscopy picture. So if you, I'm going to show you how it looks when somebody has obstructive sleep apnea. You can see that as they breathe, there is no air entry there. At the level of the palate, you can see that there is very little air entry, and you can imagine this person is making efforts to breathe and making very loud noises. With the Inspire on, at the base of the tongue, the device gets open. You see that stimulation keeps the airway open. Those are the vocal cords. That's the windpipe, and that's at the level of the palate, which is the most critical portion of the airway. So despite making an effort to close, the device forces the airway open without the patient waking up. So with very little stimulation, this device is able to keep that airway open throughout the night. So definitely works. Not for everybody, but it's a good option. Moving on to insomnia, which is one of the things you are interested to hear more about. Insomnia is defined as the difficulties falling asleep or staying asleep associated with some sort of a daytime symptoms. In other words, it's not just that occasionally you have trouble falling asleep or staying asleep. You have to have daytime symptoms despite having an adequate sleep opportunity. And that's important because if you're a night worker that sleeps through, I don't know, works night shifts some days, day shifts the other, that's not an adequate sleep opportunity. You need to have a regular schedule and opportunity, and yet despite all of that, you cannot fall asleep or stay asleep and you have daytime symptoms. It's very common, as we discussed, 10% have chronic insomnia, and 35% of the adult population, we said, have transient insomnia symptoms. So it's a very common syndrome. Unfortunately for women, this is one that you win. You have more chances of having insomnia than males. Lower socioeconomic status and stress of life probably brings that even higher. Older adults have more insomnia. Chronic illnesses most definitely will increase your risk. Cancer is included here. Psychiatric conditions, particularly depression, has been associated with insomnia. So those are the comorbid conditions that I call. Now, there are certain predispositions to insomnia. You have to have certain makeup to be an insomniac. And usually these are people that have type A personalities, warrior, people that just worry all the time, have this increased arousal predisposition. It's almost like they have increased levels of cortisol and tendency to repress emotions. Those are people that are the perfect makeup for insomnia. That predisposition is sort of your makeup that make you more prompt or make you a person at risk of insomnia. So Dr. Spillman is a psychiatrist who worked with us in Danbury Hospital a while back, and he created this graph, which I'm going to walk you through. It's called the 3P model of insomnia by Michael Spillman. And what he described is, in order to have insomnia, you need to cross a certain threshold, which is a certain level. And all of us have a baseline predisposition that I just discussed. Let's say you are a type A personality kind of a person. You worry, you have this anxiety baseline, but you need to cross that threshold. What will happen? Well, some things will happen: work stress, a disease like COVID, job loss, death, divorce, a major lifestyle change, or an illness. All of that will precipitate you going over the threshold. So now you have insomnia, right? You have your predisposition here. You're the kind of guy that will likely have insomnia, but now you have a problem. You went through this threshold, and now you have insomnia. Now you can't sleep, you can't stay asleep. You got ill, you got sick, you can't stay asleep. You went through that. So that's when acute insomnia occurs. What happens next is we develop these habits that will perpetuate the problem. Those are called insomnia perpetuation risk factors. And what are they? We tend to nap. We say, well, I didn't sleep all night, so I'm going to try to nap so that I can catch up with my sleep. Or I'm going to drink a little alcohol in the evening to see if I can get myself into a good quality sleep. Or I'm going to stay longer in bed to try to see if I can doze off on and off. So all of those behaviors are exactly the opposite of what we need to be doing. So by eliminating some of this and educating our patients about this, we can already make a little bit of get some progress. So now you have created a situation where you had your personality baseline, you crossed the threshold because of whatever happened to you, and now you added another layer of issues which are your own doing, perpetuating the problem, which leads to chronic insomnia. Now you became a chronic insomnia patient. So by dissecting each one of this, educating patients and analyzing in each particular case, that's why when I gave these presentations, people always expect me to give them a recipe of a miracle type of pill or something that will fix everything. And unfortunately, you can't do that because each person has differences in each one of these elements. And that consultation that I do is intended to dissect exactly that and understand if you are this kind of person that has this personality, what led to the problem and what are the behaviors that perpetuate the problem. So we do an interview. It's a long interview, usually 45 minutes. Sit down and talk, just to talk. We talk about your health. We ask information about medications. We ask about everything else going on in your life, including your psychological and psychiatric health. And then we ask for some data, which may or may not require a sleep study. Or more often than not, I don't ask for sleep studies unless I pick up on symptoms or signs that point to another sleep disorder like obstructive sleep apnea. Daniel Boise is a doctor that I really admire. He's a psychiatrist in Pittsburgh, and he developed a plan of treatment called Brief Behavioral Treatment of Insomnia, which is BBTI. Cognitive behavioral therapy for insomnia has been the traditional treatment for this. His abbreviated form is intended to be delivered in a quicker format, even by APRNs and nurse practitioners with very little training, but intends to discuss and address health sleep practices, which is short for sleep hygiene, education about what controls sleep, which is what I just gave you, and then the behavioral treatment, which we'll go into in a minute. So his main 4 recommendations for people with sleep issues are: reduce your time in bed. Can't emphasize enough how important this is. And the basics of this is something called sleep restriction, which is a study that was done throughout the years, recognizing that the longer you stay in bed, not sleeping or doing things other than sleeping, the worse the problem will become. So by reducing your time in bed and limiting it only to the time that you're sleeping, you will improve your efficiency, we call it, and that will create a combination of factors in your head that will improve your own confidence about your sleep. Be regular about your bedtime and wake up time. No matter how much you slept the night before, you have to get up at the same time every morning. Here's what I hear: well, I didn't sleep last night, I had to stay longer, so I got up at 9. And then the next day, I went to bed at 2 in the morning and I got up at 11. So here's where understanding the circadian rhythm will help you sink into your own biology so that you can help yourself get a better quality sleep. Don't go to bed unless you are sleepy. What does that mean? There is a biology to your sleep. And if you are not ready, if your brain is not ready, if you don't have enough adenosine in your brain or the circadian rhythm hasn't kicked in yet, you're probably not ready. So you're going to be going to bed, you're going to be tossing and turning, and you're going to be looking at the clock, which is one of the things that I emphasize to my patients: eliminate the clock from the room. And it will create a cycle of anxiety that will perpetuate the problem. And if you are not sleeping, you get out of bed. You don't stay in bed. And what do I mean by that? You get out to a chair or a commode, you read, you listen to music, but you should not stay in bed if you are not sleeping. And those are the basics, kind of the mandates of good quality sleep. So it seems counterintuitive, but Daniel Boise's recipe for this is: if you're sleeping soundly, you can increase your time in bed. But if you're not sleeping, like an insomniac, you need to decrease your time in bed. Exactly the opposite you would have otherwise done. So great advice that also includes adding exercise. And one thing that I always tell patients is, if you were to exercise and decide you have all the time in the world to exercise, you should probably aim at exercising at about 6 to 8 hours before your bedtime. That is the ideal time. So let's say for someone who aims at 9, 10 p.m., you should exercise in the afternoon, mid-afternoon, 6 o'clock. And what do I mean by that? You are talking about a good brisk walk or an aerobic type of thing, on the treadmill, on your bike, walking the dog, something that makes your heart rate go up. Your routines are critical. If you modify your daily routines every single day, you will not train your brain, and we are creatures of habits, and sleep is particularly susceptible to habits. Medical conditions and medical problems have to be addressed, and here's where medical treatments may impact the quality of sleep. A comfortable room, dark, quiet, and ideally cool, is important. So you need to have a lower temperature. I read somewhere that 67 degrees is the ideal temperature, although I don't know that I care about that, as long as it's not hot. And again, keeping your sleep for sleep only and sex. Again, remember that your bed and your sleep is a protected time. You cannot use your bed as your desk, your laptop, your music area, your conversation area, your TV watching area. Sleep and your bed should be protected. And you should have another piece of furniture in the room if you want to do that, if you want to watch TV or if you want to eat or snack or work on the computer. But your bed should be only for sleep. What makes sleep worse? Caffeine. We talked about that. Something new about it is caffeine affects your sleep, even if it is early in the morning. You got to be mindful of that. Alcohol most definitely would not help. Excessive worrying, concerns, and thinking, which leaves me with a recommendation. I always recommend patients to leave some time during the day. It's called the worry time. And the book that I'm going to recommend in a minute, No More Sleepless Nights by Peter Howry, which Kevin will list for you. So don't worry if you don't catch that reference, because I already gave him that reference. It's one of the main books I recommend to all my patients. The worry time is as such. It says, try to save some time in the afternoon to sit down in front of a piece of paper and write all your worries and concerns in one column, and then on the next column, your solutions and problems. How are you going to fix the problem? And then when you get those intrusive thoughts at night, which you're going to start worrying and thinking about every single thing you need to do the next day during the nighttime, you know that you have that appointment made for yourself for the next day. That's called the worry time. And it seems silly. It seems like it's not going to work. But if you do it routinely, you'll realize quickly how effective it could be. Work in your environment. Make sure you have good windows, noise canceling windows, darkness, cool temperatures. And again, use your bed only for sleep. Don't use it as a desk. It's not your office. So Kevin asked me, what is sleep hygiene? Well, you could look into the National Sleep Foundation, and there are good references about that. But in general, it boils down to avoiding excessive time in bed, a regular bedtime and wake-up time, a good routine. Exercise is critical. Avoiding caffeine and alcohol and smoking. And again, avoiding means avoiding it, not just less. So I work with my patients in winning down alcohol and caffeine, and I've been more recently fixed in getting people off caffeine altogether. Eliminating noise, light, and room temperature. This is from David, who is another guru in medicine in Hopkins. Again, key elements that seem easy to do, but they're very, very, you gotta check all the boxes to really make an impact. So this is the book that I recommend to all my patients, No More Sleepless Nights, Peter Howry. He's a program director of the insomnia program at Mayo. I had the privilege to work with him many afternoons. And he wrote this book, which is basically completely cover to cover of great advice, very specific advice that are very, very evidence-based and extremely effective. So what do I recommend? This is from a letter that I got from him. He writes every patient a letter and emphasizes what he feels is the most important and applicable to that patient. But I tell my patients, cut down on your time in bed. The longer you stay in bed, the actual worse your sleep will be, because what I tell my patients is almost like a bubble gum. If you spread it out, it will become weaker and weaker. So try to limit your bedtime to only the sleep time. A regular awake time is critical. If you don't do that and you try to compensate by sleeping longer, you're gonna affect your circadian rhythm and affect your capacity to fall asleep. Eliminate the clock from the room. And I'm not talking about turning it or I don't have my phone or I turn my phone back. I'm talking eliminating the clock from the room. And I'm serious about this. What I mean by that is you should have no idea of what time it is when you wake up in the middle of the night, other than the fact that it's dark and your alarm hasn't gone off, which means you are not ready for work. There is no need for you to know what time it is. If you wake up and it's 3 o'clock in the morning and you tell me in the interview, I wake up every single night at 3 in the morning, I know for a fact you're watching the clock. You're looking at the time. And that's how I know how patients are cheating. The scheduling of the thinking time is another technique that I always recommend to all my patients, which is this evening appointment with yourself to fix the world, if you would. One of the newest things there is right now is talking about Zoom meetings and telehealth. There is a lot of therapy done online, just like what we're doing right now, like this conversation. There is therapists. Kevin does sort of the same kind of work in his treatment plans, but sleep has become, particularly after COVID, particularly one of the areas where telehealth or video telehealth delivery has been pretty common and very popular. I do recommend Sleepio as an app. I like it. It's a relatively good behavioral technique, phone delivered app. Unfortunately, you have to pay for it. There are others. I think you could search around and look for whichever you like. Headspace and Calm is a very good one. Those are both good ones. They have meditation plans. They have kind of a walkthrough things. They do what we do in the office by just educating patients about what sleep physiology is, what sleep hygiene is, what can you do, what can you improve, and then they have some meditation techniques embedded in. So diving into cancer and sleep fatigue, I just want to start by saying that fatigue is a very common complaint, and insomnia is a very common complaint. This is an outdated data, but 1999, a phone survey reported that patients with breast and lung cancer reported a 44%, 44% of them reported sleep issues. The main treatment of sleep disorders in cancer still remains cognitive behavioral therapy, which is what I just went over a little bit informally with you, but it's not medications. So I just want to start right off the bat by saying drugs are not the solution. And behavioral therapy, it's hard, it's hard work, but it's the only thing that really helps patients. There is a new concept that I'm sure you are familiar or may have heard of, something called chronotherapy, which is trying to align the circadian rhythm of your sleep with your cancer treatment to maximize their efficiency and to minimize the risks of side effects. And we'll go into that in a little detail. So I just looked at what's out there now, and I came across this reference in Journal of Clinical Sleep Medicine in 2009, where they look at trouble sleeping or insomnia, depression, and fatigue in cancer patients. And no surprise, there is a huge association between severe insomnia with fatigue, physical pain, and depression. So, and the purpose of the study is not just to show the obvious or document the obvious association, but also to isolate how treatment of insomnia could also improve fatigue and depression, and vice versa. So I think when I think about cancer patients and cancer survivors and patients that are going through treatment that have insomnia, you sort of have to approach them in a multi-fashion way with the help of a psychiatrist and a psychologist to address their depression the pain doctor to address the pain and physical discomfort that they may have from the treatment, but all of which will lead in insomnia. And by adding the component of the behavioral treatment of insomnia, you improve in the other ones. And it's a bidirectional way. This study, also in the Journal of Clinical Sleep Medicine, showed that there is no question that behavioral therapy, which is the top line, is superior to, I'm sorry, this is the behavioral therapy. These are the reported health questionnaire of how the depression went. So you can see that by doing behavioral therapy, patients continue to have symptoms of depression, as opposed to behavioral treatment showing improvement in their symptoms of depression. So there is no question that behavioral therapy reduces depression and insomnia in cancer patients. So behavioral therapy is the #1 form of treatment for both insomnia and psychiatric conditions in patients with cancer. Chronotherapy is, in a nutshell, and I'm not gonna, I'm not an expert on this. I don't do this routinely, but I know of it. It's something that cancer doctors are very familiar with. And, basically what you're looking at is looking at timing of your treatment to minimize side effects when in relationship to the circadian rhythm. So that, as just a reminder, you have this central clock that regulates all these other peripheral clocks that you have in your organs. And you can affect the clock by exposing yourself to light, different temperatures, exercise, nutrition, and pathogens, all of which they're called site givers because they actually modify the circadian rhythm, can affect your biological clock. And just to give you, for example, some chemo agents that have been studied with chronotherapy. For example, cisplatin in non-small cell carcinoma, have been studied in chronotherapy. So depending on the peak of delivery, there will be an effect, 5-FU in digestive cancers, colorectal cancers. For example, this irinotecan chemotherapy, better tolerability in the morning delivery in men and in the afternoon in women. So by understanding how each agent can be used and can be delivered in different times, doctors can actually maximize their efficiency and also reduce the risks of side effects. This is one of the newest articles about cannabis and sleep. It was also published in Journal of Sleep Medicine. And in a nutshell, what they did is they reviewed tons of citations, about 336 citations between 1946 and 2020 from different databases, and they distilled down to 40 articles that they felt were rigorous enough and well-designed to study the effect of cannabis in sleep. The summary, you're not gonna like. The results are inconsistent. The results of the use of cannabis in sleep is still unclear as to whether there is a benefit. And in fact, there is a potential for long-term downsides of using cannabis. So while I don't discourage it in my practice, when patients ask me, what do you think about it? My response is, we still don't know, and we still don't have strong evidence to say that it's effective. Do I see it used every single day? Do I see good stories about it? Yes. However, the science is not yet clear as to what are the long-term effects, and we don't know whether or not there could be some downsides of long-term use of cannabis in sleep. In my experience, particularly with cancer and cannabis, it has been helpful for many of my patients because of the treatment of pain and because of the treatment of anxiety. But for insomnia per se, I cannot say yet that I will be willing to recommend it, although I don't discourage it if patients want to. So I think that's, for me, all I have. I want to thank you. And I know I went through a lot of information. I wanted to put this out there, and now I'm free for all the questions for you. I know it's overwhelming, but hope that this was at least informative in some aspects.
Thanks, Dr. Mendez. Could you just close off your
I will
screen share?
definitely do that.
Great.